Hello, everyone. This is Lynn Crawford from the Hope Dementia Support Groups. I am very pleased to have Kathy Gordon with us today, an occupational therapist from PeaceHealth. Before I introduce Kathy, please note that we have a Q&A button on the bottom as well as a chat button, and you have the ability to ask your questions by those two buttons at any time, and then we will ask them when Kathy is done. So, Kathy Gordon, please introduce yourself.
Well, hello, everyone. I'm so pleased to be here. My name is Kathy. I'm currently working with PeaceHealth Home Care, and I've been an occupational therapist for about 20 years. In my practice, I specialize in neurological changes and dementia in particular. So I'm just really pleased to be here to share information that I've learned along the way, to hear your concerns and do some problem solving with you and give you some basic approaches that might make your life a little bit easier. So tonight we're going to just cover some background about brains. We're going to look at some different frameworks that we can approach the problems that come up. Look at some specific ideas to solve those problems. And then look at some specific examples that can be hard for people who are experiencing dementia. For example, showers that need to go home, and just try to generate some ideas for you so that you can put them into practice to make your life better. Again, thank you to Lynn and Julie for inviting me tonight. I'm just really honored to be here. This is an area of practice that I feel very tied to and very passionate about. I think that with education and some framework, it's an area that we can have a lot of impact in. And I want to also thank you, the caregivers, for taking on a very difficult role of caring for your loved one as they go through the process of dementia. And as much work and effort as it is, I hope you're also finding a lot of joy in the ability to make your life better and to make your loved one's life better. So a little bit about occupational therapy. When I was I started out working in computer science, and I did all kinds of computer support, and I hit my mid-30s and I thought, boy, I'm going to be working for 30 more years, so I'd better really find something that I feel more tied to. And so I chose occupational therapy because I feel that good health comes through doing things that you love, from being able to do things that bring joy to your life. And when you have a change such as dementia or a stroke or a heart attack or any kind of health impairment, it can really impact your ability to find joy. So, being an occupational therapist gives you the chance to help people get past those hurdles and be able to engage in activities that they love. And central to that practice is this idea of purposeful occupation. And we think about that as that feeling that you get when you're totally engaged in doing something that you love, whether it's gardening or sewing or taking a walk or making music or listening to music or making dinner for your family. It's also very functional and centered around activities of daily living. So it becomes very basic at certain times, getting dressed, having a shower, getting to the toilet, all that kind of stuff. And one of the common frameworks that we use with occupational therapy, we call it the person, environment, and task framework. And so we always try to maximize the person's ability. And then we look at environmental changes that can be made to make a task we're able to be done. And then we look at the task itself and whether we can simplify it to make it easier to do. And so the goal of tonight is to give you ideas and potentially a different way of looking at your day so that you can ease the way of the person with dementia that you're caring for. I have to say I'm relatively new to the HOPE group, and my first experience was last month, where we had the end of life discussion. The doctor who was, spearheading that the program, and I think he's also a teacher and very used to speaking kind of up on a podium. I am not, so I'm gonna maybe stumble through a little bit tonight, and I apologize in advance for that. We're gonna have a lot of time after my initial introduction for your specific questions and ideas that you would like to share with the group as well. So here we go. When a person has dementia, I think it's helpful to think about them as a person with a broken brain. And when you can think about that, their behaviors that may change aren't necessarily something that they're doing to irritate you, even though it might be irritating, but it's because it's the best they can do because their brain is broken. So when a person has a broken leg, it might be obvious they can't put weight on that leg or they can't walk. When a person has a broken brain, they may look like the very same person that they've always looked like, but they don't think the same way that they always did. And in particular, the abilities that are impacted first are the high-level executive functions. So, for example, planning your day. You and I wake up and we just figure out what we're going to do that day, whether we're going to work, whether we're going to the grocery store, whether we're going to meet up with friends. Planning the day is something that's very hard for a person with dementia. It's a very high level function and it's hard for them to do. Another thing that's very hard is to anticipate what's coming next. So that ability to kind of put into the logical steps of what to expect. You do something and then you have an outcome. That kind of a thing is very difficult for a person with dementia. And as a result, they can have a very limited ability to be rational, and they can have limited insight into the consequence of their actions. And so as a result, it can be difficult to do something that used to be easy. So, for example, I used to work with a nurse who had a large family. Most of them worked in healthcare, and their mother was experiencing dementia changes for a long time, but none of the people in the family recognized it until they all went to their mother's house for Thanksgiving dinner, and she put a raw turkey in the middle of the table, not knowing that she had to dinner first. This was really their first clue. So, dementia impacts people of every social situation, every economic situation, and it can be hard to recognize because people look the same, even though they're not acting the same. As we age, our personalities become more amplified. With dementia, that amplification loses its filter to know the difference between right and wrong. And people can sometimes say inappropriate things. They can become more easily agitated or angry. And oftentimes that agitation is their expression of an unmet need, whether they're constipated, whether they're hungry, whether they have pain. So it's really helpful if you can kind of step back and look at the person. What is it they're really trying to express with this outburst? And again, to know that it's not that they won't stop repeating what they just said, it's that they can't stop repeating what they just said because maybe they're at the stage where they can't remember that they just said that. And recognizing that as people go through different stages of dementia, they'll have different capabilities and they may demonstrate personality changes every step along the way. Other physical changes that can happen with dementia are changes in their vision. And so when we walk into a room, one of the normal things that we do is scan with our peripheral vision, so we get a whole sense of what's in a room. A person with dementia may become very much tunnel vision, so they only see what's right in front of them. They may be unaware of their own physical needs because of nervous system changes and musculoskeletal changes. So they may not realize they're hungry or thirsty. They're at higher risk for dehydration. They may not realize they need to go to the bathroom, so they may become incontinent. They may be overall a little bit weaker or have balance problems and need to use a walker for the first time when they didn't used to have to do that. Let's see if I don't want to. I'm kind of getting some of the harder things out first. Another thing that may happen is that they may be very easily overwhelmed because their processing of information, visual information and audio information, spoken information, it takes them longer to process it. So by the time they're realizing what question was just asked of them, a conversation may have moved on to the next topic already. So these are just some of the changes that can happen with the brain. Those are not changes that happen with normal aging. Those are indications of an abnormal aging process, often tied to dementia. So what can you do about that? Well, there are a lot of strategies that you can do, that you can put into place to make it easier for you to care for a person with dementia. The first one is to really do good self-care, to make sure that you're doing things that you need to do to take good care of yourself. You've heard this 100 times. You can't care for someone else if you're not taking good care of yourself. And yes, it's a cliche, but lots of cliches really work. And this is one that really does work. So if you don't already have a good plan in place to take good care of yourself, write down the steps. What does good self-care look like for you? And put those steps into action. You know, the fact that you're all part of a support group is a great first step. But, you know, you can always re-examine that and do maybe a little bit more for yourself. It's not a selfish thing to do at all. It's a very practical thing to do. Educate yourself so that you know what to expect and you know how to respond to your loved one's needs. And ask for help. And I know this is a very hard thing to do, but it's also a very hard thing for the people in your circles to know how to respond to. They'll, you know, we get offers all the time. Let me know what I can do to help. And what's our first response generally? Oh no, I've got it. I'm okay. I can do everything. Sometimes that's true. So maybe you can do everything, but a lot of times, even without even knowing it, we're carrying a heavier load than we need to. So this is a great time to call in the troops, ask for help from your neighbors, ask for help from your family members, ask for help from your friends. And if there aren't people in your circle that know how to help or can provide that kind of support for you, look into the option of paid caregivers if you can afford that. Another strategy to put into place is to adjust your expectations of the person with dementia. They look the same, but they're not the same person that they used to be. So adjusting your expectations and just recognizing that they aren't capable of doing what they used to do is a really important step for you. When you're interacting with a person with dementia, you of course want to find ways to involve them in activities that give meaning to their life. And we'll talk a lot about that. But one of the approaches that works really well is to be very reassuring. And I will use the phrase safe and sound all the time. It's It's nice to give people words that they can hold on to. So when they wake up in the middle of the night, not knowing where they are or not knowing who they're with, they can remember that phrase, safe and sound. So I use that all the time. You want to avoid the words, don't you remember when, blah, blah, blah. Because oftentimes they're not going to remember, and they don't want to have to admit that to themselves or to you. And when you're interacting with someone, and this is everything that we're talking about tonight is also going to depend on the stage of dementia that they're in, but it's okay to say what they need to hear. And by that, I mean, if you need to go away for a trip for a couple of days and your loved one is worried about you not being there, it's okay to say, I'll be back soon. You don't have to say, I'm going to be gone for a week and it's going to feel like forever to you. You can say, I'll be back soon. You can, but in the meantime, I'll talk to you on the phone regularly. So you can always say what they need to hear. That's a really good strategy. It benefits both of you. It brings their anxiety level down, and it gives you the freedom to do what you need to do. So, for example, even when your loved one is saying that they're, just had a visit with their mother who has passed away 30 years ago, it's okay to say, did you have a good visit? What did you talk about? What was it like? Did you talk about, what a day was like for you? Or did you talk about what it was like to have 6 children growing up in Nebraska? There's no reason to reorient them to the reality. You don't have to say, don't you remember your mother passed away 30 years ago? You can just be part of the story that's going on with them now. Another good strategy is to avoid open-ended questions. So instead of what would you like for lunch, you can say, do you prefer egg salad or peanut butter sandwich for your lunch? And you can say, here's your egg salad sandwich. And if they don't seem to like it, offer them something else. But you don't want to have those open-ended questions because they become more and more difficult to answer. Another good strategy is to model the behavior that you want the person to do. So, for example, if a person is unsteady on their feet and you need them to sit down, a great strategy is to take their hand, is to stand beside them, to take their hand that is next to you, put your arm around their waist and make a sitting down and sit down. Start to sit down yourself. They will imitate what you're doing with your body, and you'll be able to get them to sit down easier if you need them to sit down. Another really good strategy is to do activities together. So I've had people who say, the only thing my mother can do is sit and watch TV these days. But when I brought out colored pens or colored pencils and, coloring diagrams for everybody to participate in, and we sat around a table, the person with dementia who everybody thought could only watch TV sat and colored with us and had, a great, meaningful interaction. When I was working in a skilled nursing facility, we had a woman named Dorothy, and she had pretty progressed dementia. And we had a baby shower for one of our coworkers, and Dorothy attended the baby shower, and she was totally appropriate. She was totally engaged in the baby shower. She knew just what to ask. She even identified the person who was having the baby, and talked with her in a very appropriate way. So doing things together as opposed to just handing somebody something is a great way to engage them. You want to simplify their environment, but keep familiar items with them. So you want to help people not be quite so overwhelmed by kind of making sure there's a nice big pathway for them to walk through, making sure they know how to call for help if they need help, and then having familiar objects also in the room. Think about lighting. As I said, people's vision can be impacted by dementia, and so brighter light is usually helpful. And having a task light that shines right from behind them, that shines right on an object that you want them to see, can be really a great way for them to see their dinner plate, for example. And another very good strategy is to talk to them kind of one step at a time and let them know what to expect so that you can help them manage their expectations. I think that's a source of anxiety for many, many people who have dementia. They just don't know what to expect during the day. Is it going to be a great day? Is it going to be a day where they're at loose ends and don't know what to do? So, if you establish a regular routine where they wake up around the same time every day, have meals at the same time every day, have medications at the same time every day, have some kind of activities planned for different stages during the day, whether it's listening to music, listening to a book on tape, having phone calls with their friends, having FaceTime, looking at a picture book, a photo album, adding structure and adding a regular routine, and managing their expectations is a really great way to keep people's anxiety level down. And then just recognize that change can be really hard on a person with dementia. It can be really hard on people who don't have dementia. So it just gets amplified when the brain isn't working perfectly. And so it can take like up to 4 weeks to develop a new habit. So if a person goes from walking without any assistive device, as we call it in the business, to needing a walker or a cane, it can take about 4 to 6 weeks to get used to a change like that. So try to make those changes before they're absolutely critical, when a person can still adjust a little bit easier. And by that, I mean, if a person is starting to have some balance problems but hasn't had a fall, you might think about introducing a walker early rather than later in the game. Another idea is to use the phrase, rather than "you're going to," how about "let's try this for a little bit." So especially when it comes time to move places, that can be a really hard change for somebody. And so if you approach it with, "let's try having you live at this place for a week," and then the week comes along and it turns into another week, or sometimes it just doesn't work at all to have a move and it gets reversed. But having a framework that they can hear and accept, "oh, okay, I'll just be here for a week," can be much easier than hearing, "this is my home for the rest of my life." I mentioned music a little bit ago, but familiar music to the person can really help settle their brain. Drumming, rhythmic music and drumming and chanting, we're seeing some really great responses to that kind of very predictable, very simple sound. You do want to avoid watching too much news because it can be hard to differentiate someone else's reality with your own. And watching horror movies can be kind of hard on people as well. And then one of my last ideas to share is when you've got like a family photo album, for example, it can be a little bit overwhelming for people because they may not remember all the people in the photos, and they don't want you to know that necessarily, right? They don't want to hurt anybody's feelings by them being the forgotten one. So think about arranging family photos and friends photos with just one person in the photograph on a page, and put their name in large print at the bottom. That can be a nice way to identify who's on the phone with them. And it can be just a nice way to reminisce about, remember, oh, this is Barry. He was our neighbor for 5 years now. He lives in Chicago. You can kind of start the story about Barry. Well, Barry's picture is right there too. So the take-home message in all those different strategies is really that what you want to do is find ways to involve your loved one in activities that give meaning to their life. So, if they were always the ones who did the cooking, but you don't want them to be doing the cooking without supervision, or you know they're not going to be safe with a knife, or they're not going to know what to do with a knife. Well, make 95% of the soup and let them pour in the noodles at the end, for example. So that's my introduction, and I think I'd like to talk about showers next. I'm going to come back to the Zoom screen because I've been reading. And so showers. Why are showers hard for people? We've been doing it all of our lives. Why does it become difficult for a person with dementia to have showers? Well, it just depends. It becomes difficult for lots of reasons. Maybe it's hard for them to step in and out of the tub reliably. And so if that's the case, there are environmental changes that you can make to depending on how much time and money you want to spend. You can turn your tub into a step-in area. Hello. You can put in grab bars. You can keep the tub and put in something called a tub transfer bench. And that's another piece of durable medical equipment that is often used for people. Tub transfer bench is a little bit different from a shower seat because it's extra wide. Part of it is outside of the tub. Part of it is inside of the tub. So you sit on the outside part, you swing one leg and then the other leg over the lip of the tub, and then you scoot your bottom inside, and there you are inside of the tub. Water can be kind of a hard thing to experience when you have dementia. It can be hard to understand water. So, having a handheld shower can be really helpful because the person can be the one to hold the handheld shower and do the spraying. You can certainly have your hand over their hand if you need to. Getting undressed in front of someone else can be kind of intimidating. So one idea is that you can let them get into the shower and they can take their own clothes off inside the shower. Again, these are just ideas, and what you want to do is you look at the person and rely on your knowledge of the person to kind of determine what the barrier is. Sometimes people just don't like to be cold, and showers can be cold even if you've got hot water. Person's temperature regulation system may be impacted by changes in the brain, and so they may be getting cold. So have a spare heater in your bathroom. Have lots of extra towels. Put the towels inside the dryer before you start so they're nice and warm when the person gets out. If they are sitting on a shower chair, on a plastic shower chair, put a towel down so that their bare bottom isn't going to be on the chair. Take a shower with them, you can keep your clothes on, but if you're having the experience too, it can be easier for the person to participate in the shower. And the other thing is, think about, do they really need a shower, or is a sponge bath okay? So that's just different ways of grading the activity so that it's less challenging for the person and easier for them to accept. Again, this is all going to be a very personal thing. Some people with advanced dementia are just fine with showers, and other people with mild dementia just can't even stomach the idea. So it's a very individualized kind of experience. Another situation that I think a lot of people find themselves in is their loved one wants to go home, even when they are home. And that's a conversation that people will have, kind of a circular conversation. I want to go home. You are home. I want to go home. We're home. This is home. I want to go home. And that's not doing anybody any good. So how do you break out of that cycle of conversation? Well, lots of ideas for that. But the main one really is to create the environment so that it's filled with familiar objects so that they can recognize their own objects. And it could be the case that they're going to pack up their pictures, their family pictures, and have them ready in the morning so they can leave and go home. It often happens. Diversions and distractions are great. You want to go home. Well, okay, let's work on that plan. We'll go in about 2 hours. In the meantime, I just made cookies. Would you like a cookie? Cookies can be a great distraction for people, or whatever favorite food that they have. Hot tea, whatever. Or in the meantime, let's make a phone call. We'll call, a family member and see what they're up to. But one of the harder things for them to hear is, you're already home, so I'm not going to do anything about this request. Think about where that request comes from. It's going to be some unmet need. And it might just be a need to have a conversation with somebody, because that's what you do when you're at home. So money. Oftentimes people with dementia are, especially when they come from the depression generation, they're worried about money. And they know that life is expensive and they don't have any money, or they don't know where their money is. So it's not a bad idea to keep, bank account statements where they can at least see them, so they know they still have bank accounts. You can keep one or more wallets or purses around, put a couple of bucks in them so that they can find them, know that they have them, know everything's okay, know that they're safe and sound, their money's okay. Be reassuring about it, and give them some physical evidence. See, you've got money, it's right here. Here's part of it. Here's your bank account. Here's your wallet. You may end up unhiding that wallet multiple times throughout the day or the week, but that's okay. They get the reassurance of knowing that they've got it. One of my friends, her mother stayed with her through, not through end of life, but through fairly advanced dementia. And her mom got to a point where she just did not like to be alone. So my friend would be in the shower and she'd open up the shower door and there's her mother waiting for her without her walker. So she set up I thought it was a great idea. She got a big timer so her mother could see the timer. She set her up with a foot bath so that she could enjoy like a little foot spa, and she could look at the timer and know that she had 10 minutes left, 8 minutes left, 6 minutes left, and have a little spa activity. And that gave my friend a little bit of time to have her shower and get her day started before her caregiver got there. Photo albums. Reading is another thing that can be awfully meaningful to people, and it can be hard for a person to read. So some ideas around reading are, get large print books if they're still able to read. You can read along with them. You can have 2 copies of the same book, give them the page so that they can follow, but you're actually reading aloud to them. If you're tech savvy or you've got grandkids or kids who are tech savvy, and we'll set up Alexa. That's a nice way to have an audiobook read aloud. A lot of the libraries, including Fort Vancouver, have audiobooks available to borrow. So you can do that through Alexa or any speaker or smartphone. And I think that might be what I have to say for my intro. And I'd like to open it up to questions and interactions and see what your ideas are. But I don't know how to do that. So
That's
Julie.
all right. We're good.
Okay.
I'll ask you the questions. So our first question is, how do you get an occupational therapist to come out to the house?
Yes. So out to the house, there are a number of people in town who have private practices and will come out to work with you individually. If you wanted to go through a person's insurance, and they can qualify for home health services. So therapy happens in a few different settings. Hospital setting have therapists, outpatient has therapists, and home health. Home health you can generally get if a person has had a significant change in their health, which leads to a change in their ability to function. And it just takes a referral from your doctor, and that referral can be taken to any number of home health agencies in your community. So in our community of Vancouver, we have PeaceHealth, who I work for. We have an organization that used to be called Gentiva, or it's been bought and sold several times. I know a number of the therapists there, great people. We have community home and hospice, kind of more widely known for their hospice services, but they also have home health. So home health will always involve either a nurse, physical therapist, or speech language pathologist, and then occupational therapy is added on to one of those services. That's the way Medicare structures it, so that's the way insurances structure it.
We've had a couple of folks asking about ideas about dealing with dementia patients that elope.
Yes, that exit.
What ideas you might have to keep them safe?
Yes. So there are lots and lots and lots of different styles of monitors that you can use for a person. I don't know, frankly, I don't know how I missed that in my outline, but sorry. So you can use a simple baby monitor to monitor a person's activity. You can use, and all of these things are available on Amazon, which, by the way, I have to say, as much as I don't like rampant consumerism, boy, Amazon and just the whole selling of things has certainly helped the price of medical equipment come down. So none of these things is very expensive anymore. So simple baby monitor is one idea. So you can hear what's going on. A lot of people put up cameras these days because those are also much less expensive than they used to be. If you want motion sensor, they have lasers that you can put kind of across the doorway or across or next to the bed, so that if a person gets up at night, it sets off the laser sensor. They have motion sensor pads that you can put on a chair or a bed. So if the person gets up, those are kind of my least favorite kinds because they tend to be kind of obnoxious sounds and not as easy to program. Another idea is to set up a diversion. So if a person gets up out of bed in the middle of the night, this is everybody's worst nightmare, right? They get up out of bed, they wander off in the neighborhood. You don't know anything about it until the next morning. So it's a genuine concern. So another idea is to set up a diversion for them so that they can, maybe be headed somewhere. But if they used to work in an office, you set up a table with an office chair and a telephone and some piles of paper so that they have something to do, a reason to sit down. You can, the National Alzheimer's Association has a great store, and one of the things they sell is posters that look like bookshelves. So you can put that poster over the door to make the door harder to find. You can put alarms on your doors so that they go off if the door is open. Yeah. You can have a discussion with the person's primary care provider. If they're restless at night and not sleeping well through the night, are there other things that you can add, whether it's medication or chamomile tea or, techniques like not drinking any fluid after 7 o'clock at night so that you don't have the urge to go to the bathroom to wake you up. Think of all the reasons a person might wake up. You can keep the person busy during the day so that they're less likely to wake up at night when they should be sleeping. But it's a very common problem. You probably want to get one of those ID bracelets. Some of them have little trackers on them so that you can, little GPS trackers, but at least ID bracelets that say, this person has a medical condition. Here's the person to call if you find them and they need help. So at least you have a reassurance if a person does leave the home.
We have a comment from someone that says Best Buy has the Nest camera for both indoors and out.
Mm-hmm. Best Buy, Costco, Amazon.
So talk a little bit about assessing home safety and the environment.
Mm-hmm.
What does that look like when you come out to the house to do that?
Yes. Okay. So there are a number of standard home safety tools or home assessment tools, but we look for the basics, and then we kind of watch the person go through their day. So, bathrooms, of course, are a big concern. Most falls happen in the bathrooms. And so we, see how the person gets from their normal place during the day, whether it's the living room or their bedroom, to the bathroom, to see what obstacles or what barriers there might be, and then do problem solving with them and the family members in terms of removing those barriers. But needing to go to the bathroom is probably one of the riskier things that people do. Home assessments look for general, use of oxygen tubing, safety things like, people live in all kinds of, I'll say a wide variety of environments. And so, I've been in some like super crowded homes that are totally safe because the person is so familiar with their environment. And I've also been in super high-end homes that are like really not safe because the person doesn't have the ability to do what they need to do in that home. They, maybe broke their leg and can't get from their wheelchair to the toilet safely. So it's very personal, and it's very much centered around what the person needs to be able to do during the day and what the caregiver needs to know to be able to provide assistance safely.
Can you help with independent strategies in the home, such as cooking, showering, laundry, etc., and make the safety changes and suggestions at the same time?
Do we?
Yes, is that?
Yes, that's exactly what we do. Yeah. And again, it's going to be just very individual. It depends on the person and the, the layout of the home, and, transportation is another consideration.
You had mentioned with the cooking that maybe you just allow that person to participate in the last little bit. Is that a common strategy? Does that help keep people independent longer?
Right. Either the last little bit, or some portion of it where they can take some pride in having participated. So, whether, if they're not able to safely do any chopping, maybe they tear up the lettuce, or maybe they, work on the green beans, and then you triple rinse them after the green beans are done, because that they probably weren't totally sanitary, something like that. But I think it's really just, it depends on what's important to the person, and just to find strategy. Sorry, I get distracted. These chat questions.
Well, that's okay.
Distracting.
So if the person has Lewy body dementia, are there unique home safety stuff that is to be considered?
Just that Lewy body tends to be a very aggressive type of dementia. And that, again, you want to just make things as obvious and simplified as you can. So leave the walker right in front of the person if they need a walker. Leave something to hold on to in the bathroom, as obvious as it can be. One thing I often recommend for like eating or for doing any kind of activities is to just place the object right in front of the person, the object that you want them to see. So I often will recommend the use of a TableMate style table tray. Other companies make, Rubbermaid makes a nice sturdy kind of tray, where a standard kind of a table tray will only come in so close because the legs keep it from coming in close to the chair. So if a person is sitting on a couch or a regular chair, you want to try the TableMate style, because it's got kind of, the legs have an L shape and they slide right under the chair, and the tray table can come right up to the person. It's also a nice way to keep them from, or to kind of lower that impulse to want to stand up all the time because they've got something right in front of them. It's not a restraint, but it is a nice way to keep them occupied so that they're not constantly looking for something else, because what they need is right in front of them. Lewy body, people with Lewy body dementia are going to be some of the earlier ones who need 24-hour supervision.
Can you speak to medication management? Yes. Recommendations for, that's something that people are often reluctant to give up, is managing their own meds.
Mm-hmm. Let's try it for a week. That's one strategy. Let's try it for a week.
Are there specific tools that you would recommend to manage medications?
They do have, they make these, so you're all familiar with the little Medi-sets, the boxes that, you arrange for a week at a time. They do make some that are kind of on a timer, so that it just, like when your noon medications are due, there's a timer that goes off and a door pops open to dispense the medications then. That can make it safer for people. You can get from pharmacies, from certain pharmacies, I'm going to have to look up which ones, you can get bubble packs delivered to your mailbox. And so it's prepackaged by the pharmacy. So you've got your morning, noon, and nighttime medications already arranged by the pharmacist. Your primary care can do can do a medication review to make sure that the medicines are as simplified as possible. A pharmacist can also help with a medication review like that to simplify things, so that you don't, if you're taking medication 6 times a day, you may be able to decrease it to 3 times a day. But again, if a person is reluctant to give up the medication management themselves, and you know that they're not safe to take the medications, there's no reason to argue with them. There's no reason to say, you're no longer capable of doing this. Just kind of set that aside and say, let's try it this way. We've got your caregivers here every day. Let's give them something to do. And the caregivers can be the one to hand the medications over.
How about driving?
What about driving? That's a hard one, isn't it? Oftentimes, even after people are diagnosed with dementia, they will continue to drive. And for family members, I always say, would you put your grandchildren in the back seat and let them go with them? And if the answer is no, then they shouldn't be driving. To revoke a driver's license takes an MD. So if you know that your loved one isn't safe to drive, you can talk to their primary care about it. And that's how a driver's license gets revoked. People, again, oftentimes driving is such a part of our American culture. It can be a very difficult one for people to give up. So, but again, if you know that you wouldn't put your children in the back seat with the person who's driving, then they probably shouldn't be driving, even if they haven't had accidents. And the problem is, driving isn't a predictable thing. You run into unexpected situations with driving all the time. Things that we just are able to roll with the punches. You can't do it when you have dementia. And so that's something that generally you either have to have the discussion or just, again, let's try this for a week. Instead of driving yourself, I'm going to be driving you. We're going to find somebody from church to drive you as a volunteer. Let's try Uber. Make something, give alternatives. In Clark County, for most parts of the county, you can get CVAN for medical transportation. These days we have grocery delivery. So there are some really good alternatives to that. And I think COVID kind of firmed up some of those alternatives for us.
So can you describe the process of using the simulators that they have at Legacy and PeaceHealth?
Mm-hmm. They do have driving assessments. I will tell you that they're a multi-part assessment. It usually takes 2 or 3 visits to go to an outpatient clinic to have your driver assessment done. They are required for anybody who's had some kind of a neurological event. So if a person's had a stroke or a brain injury, the primary care will generally refer to outpatient for a driving assessment. And it will consist of a cognitive screening test, like the SLUMS or the MOCA. It will consist of a simulator device where the person sits in front of a steering wheel and their reflexes and their responses to different driving situations are tested and recorded. It will consist of a vision screening. They've got these big Dynavision or something similar to that to make sure you're seeing everything that you need to see. And reaction testing, so reaction response testing. And I haven't done that for a number of years, so I don't know if they've changed that whole process in the meantime. But I know that those are some of the basic components of a driving assessment.
And if they don't pass, what then? Does that go to the state?
Yes. And the primary care recommendation to revoke the license goes to the state. The driving assessment goes back to the primary care and to the person, you know. So there are no secrets in healthcare, especially these days, because just a few weeks ago, a person, you know, it used to be when I'd go into my chart, I would only see what my primary care wanted to disclose to me. Now, as of just a couple of weeks ago, May 1st, a new regulation went into healthcare so that everybody has access to their whole entire medical chart. So there are no secrets about this. And you know, there really shouldn't be. I mean, especially early in the stages of dementia, you know, your focus is to band together to keep everybody as independent and functioning at their highest level while they're safe. And with an acknowledgement that, you know, there are unsafe people all over town, really. But you know, the idea is the reason you're, you know, being a caregiver for the person is to help them stay safe and help them not get into trouble with others as well. And that's the problem with driving, right? So such a
Do you have recommendations for those who have firearms in the house and the person with dementia will know if they've gone missing? So they kind of don't know what to do?
If the firearms have gone missing?
Yes, you know, that they need to be taken out of the house, but the caregiver is concerned about how their loved one will respond.
How can you present that to the person so that they're okay with the answer? You know, I guess I would throw that out to the group too, to see if you've had any successful strategies with that. But I would approach that from tell them what they need to hear, you know. So maybe each time eventually they're going to forget that they had guns. So it's not going to be a, you know, forever problem. But, you know, you said 2 weeks ago, you decided to give your guns to your grandchildren, and Toby got this one, and Ryan got this one, and Jessica got this one. Now we're going to try that for 2 months. And at the end of 2 months, you can say, we're going to try it for 2 months, you know. Does that help?
Indeed. Other safety issues that you've had experience with and we haven't asked about?
Well, eloping is one of the big ones. Has anybody had other ideas to help prevent elopement?
Well, I know I have a group member who has had repeated episodes of his wife eloping, and they live in the country. And so there have been frequent calls to the police to help with finding her.
That's really hard.
And trying every way that they can think of to keep this from happening.
Yeah, additional locks on the doors is not an uncommon solution to that problem. You know, you can put those fold over locks that are high so that the person has trouble reaching them. You know, the problem is if they try to open the door and the door won't open, that can send them into a panic too. So, and you want to avoid that anxiety state as much as you can. So again, you know, think about diversions. People, you know, one of the changes that can happen with the vision changes is that a person perceives a big dark colored rug as a hole in the floor so they won't go across that rug. So that can be a way to keep them away from the door. They'll just walk right around it.
Can you help caregivers identify issues with disorientation and with angry outbursts?
Yeah, so, a person who has been kind of grumpy most of their life is very likely to get grumpier in older age. So, but with dementia, sometimes the angry outbursts are really just an expression of an unmet need. So the person might be hungry. The person might have a urinary tract infection brewing. That's very, very common. A person might be having pain and they're not able to say, my abdomen hurts. They just get angry instead. So look for all of those kinds of reasons as well. Another thing that can happen is they just are detached from their lives. They might have spent their lives doing for others, and now they're in a situation where others have to do for them. So again, think of strategies to involve them in the daily stuff. Maybe they can still run the vacuum. Maybe they can, not that that's so exciting, but it is something that they can step back and say, look what I did, right? So find things that, and really the best way to do that is to just try it. Even if a person hasn't been the cook in the family, they can contribute to the meal somehow. And then, the rest of the family members say, thank you for making the toast tonight. This is the best toast we've ever had. You did it just right. And give them a sense of pride.
Have you encountered a situation where a caregiver is not safe in the home related to volatile behaviors? And do you make recommendations when you have that concern?
Yes. So if the volatile behavior is the norm, is continuing for a long time or for any period of time, again, it's an unmet need, and often that is related to physical change that's happening. So, depending on the circumstances, you may need to just call 911 and have an ambulance come out. And I know that's always hard because this is your loved one and it's not the expected behavior, but they may need medical attention. If it's just something that's kind of progressing gradually, you're just noticing increased restlessness or increased anxiety, talk to your primary care about it, or talk to their primary care about it, and see if there's a planned medical intervention, so that you can avoid the 911 call. But when it becomes a safety concern, ask for help from other family members. When distraction or diversions doesn't help, you may need to call 911. I had a dear friend of mine whose father had dementia, and she kept him with her and as long as she could, really. And she looked a lot like her mother. And so there was a stage of his dementia where he wanted her to perform her wifely duties, and it became unsafe for her. So she just couldn't be alone with her dad for a period of time. That stage passed for him, and he did need medical attention. He had a urinary tract infection. So these things all generally boil down to, having a reason, but the person can't necessarily say, I can't pee today. They just get mad, or they shout, or they blame you. Very hard, It's kind of easy for me to say this stuff. It's very hard for you to live through this. So just, if you can, just take a deep breath, take a step back, and think about what could be the root cause of their behavior, of their outburst.
Do you have times when you actually help the individual who has dementia to improve or maintain their cognitive function?
So, dementia is a disease process, and the best way to slow down any disease process is through really excellent nutrition and as much physical activity as you can tolerate, or as much that as makes sense to a person. So a person who is, very overweight and has never been physically active, you're not going to start taking them on 2-mile walks around the neighborhood. But a person who has been active their lives, it's a distinct possibility that you could still have them, go on daily walks with you. And again, nutrition is a really big component, especially water intake or fluid intakes. And, so many people are of a generation that they just don't really like the taste of water, or they're not used to drinking water. But having enough hydration, or let me put that differently, being dehydrated is the root of many, many health problems. So if you can encourage water intake, you're going to be on the right track.
Do occupational therapists help with keeping people to have appropriate range of motion, endurance, and strength?
Yes.
Are those things you deal with?
Yes, yeah. So we can often help a person get set up with an individualized exercise program, if that's something they're interested in.
Do you work with physical therapy to do that?
Sometimes we do. It's not an area that physical therapists always feel comfortable with. Different practitioners have different comfort levels.
I know there are times when people are no longer able to use a walker, or they need to change the type of walker that they use. Is that something that occupational therapy makes recommendations about?
Yes. Mm-hmm.
Can you describe that a little bit?
Yes. So, different walkers have different properties. And dementia, again, the changes that happen in the brain are sometimes, also accompanied or the result of Parkinson's disease or Huntington's disease, or different illnesses like that as well. So, there are the walkers that we're all familiar with the 4 wheels, and they've got a little seat to sit on, and that can be a really nice support for people who have breathing problems, for example, because they've got a seat there all the time, and so if they get winded, it's easy for them to sit down. It can be hard for a person with dementia because it requires turning yourself around and sitting down and making sure that you know where that seat is. So the silver frame walkers are usually a great place to start, because they go more around the person rather than in front of the person. And they're very straightforward. You just grab the handles and go. They don't have any moving parts. For a person who has Parkinson's, or might have had a stroke or other involvement with the brain, they make special walkers called U steps, they have surfaces that the whole forearm sits on, and again, it goes around the person and keeps them more upright. So those are some of the basic choices that you have with walkers. But again, balance problems come up very regularly with people. And it's really the best strategy is to introduce a walker early in a person's dementia process, so that they can get used to it at a stage of their dementia that they're still able to adjust a little bit easier.
How does an OT assist in maintaining a healthy lifestyle in individuals who have dementia?
Yes, well, it's, you look at the whole picture. And so, you look at their day from beginning to end. What resources are available to help with staying healthy? What capabilities do their caregivers have? And what is it that brings meaning to their life, and how can we get you to be able to engage in that still.
Do you assist the caregiver with de-stressing?
Yes.
And how do you do that?
And again, that's going to be very individualized. You know, we all have our own coping mechanisms, and we all have, you know, sometimes very effective ways and sometimes ineffective ways. But again, putting, you know, calling in the troops, so that you have time to step away from your caregiving responsibilities to someone else and turn your attention to yourself is a really important one. Maybe you just need to go, you know, watch a movie. Maybe you just need to go in another room and have some time to yourself. Maybe you need to go take a walk down by the river with your friend. You know, that's going to be individualized for everybody. Maybe you need to sit and read a book for a half an hour every day.
Knowing that dementia is a progressive disease,
Yes.
how is it that the occupational therapist can assist both the caregiver and the person with dementia when changes need to happen, whether it's changes to leaving the home to go someplace else or actually going to memory care? Are those things that OT can help with making those adjustments?
We certainly do help with that very regularly. And, you know, it starts with having the conversation. And I will say, I think that was one of the most valuable things that I got out of last month's talk, was having all of those resources available centered around healthcare and end-of-life care to start conversations with people, with families, because those can be very difficult conversations to have. You know, I still meet people, and it's understandable. People think that if you're, you know, bring up the subject of hospice, that you're starting the end-of-life process for someone, when in fact, what we often walk into is seeing somebody who looks like they're actively dying, but the, you know, family isn't ready to let go. So they don't want to talk about hospice because they think that that will be the thing that pushes the person to death. So I think just being able to have those conversations, candid conversations with yourself, with your other family members, and involving the person with dementia as much as they can early in the process is a really valuable tool. I'd also like to, so a couple of other things I wanted to mention. There's a book called The 36-Hour Day. If you've got copies of this, or if you've ever heard of this, it's a really, really valuable book. I think, again, you know, being part of a support group so that you can get answers to common questions is really a great step, and a wonderful way to support yourselves. I think reading these kinds of books so that you get ideas, and also know that you're not the only ones going through this. This is just a part of life for many, many, many people. And it's not easy, but, you know, you can learn things and put resources into place to make it easier on yourselves and make it easier for the person that you're caring for, and still get a lot of joy out of life. So it's not that anybody can come in and say, I'm the expert, and it's, you know, your loved one needs to move now. It's a very subjective decision. And, you know, it's a very personal decision. You know, you might be having a really horrible day and feel like you just can't even finish the day, never mind facing a whole, you know, 6 months of doing this. But, you know, then you make adjustments, you get in some extra help, you lean on people, your loved one turns around for some reason, they get an antibiotic for their urinary tract infection, and it's a whole new day again. So But yeah,
Often
we
people-
lead those kinds, we help people through those kinds of discussions and decisions all the time.
Often people who are dealing with dementia kind of forget about the other illnesses that might be coming along with this person who is older. And do occupational therapists typically help keep these other diseases at bay? And how do they do that?
We definitely have ideas about what to look for, and we coordinate with our team. None of us, even in practicing in healthcare, none of us operates alone. So no OTs, we can't, diagnose, and we can't prescribe medications, but we can call a primary care provider and say, this is what I'm seeing. This is consistent with something that I've seen before. Would you consider prescribing? So this person has uncontrollable vertigo with nausea and they can't stop throwing up. Would you consider using meclizine for a medication with this? So it's all part of, communication, and it takes a village, right?
You mentioned the fact that vision changes. How does an OT assist with vision loss?
Right. So vision changes and loss of vision is very common with dementia because of the different parts of the brain, and because, back in the 40s, they did that study that said this part of the brain is responsible for this and this part of the brain is responsible for this. Well, we found out years later that those studies were all done on young white men. And it's true. There are control centers for different aspects of controlling the body in the brain, but we know now that the whole brain works with the whole rest of the brain to keep our bodies in homeostasis and functioning well, and being able to respond to infection and being able to respond to injury, and digesting food, and the whole brain wants to chip in. So with the vision loss, a lot of occupational therapists are trained in specific vision techniques. So there are sometimes, things that you can do nutrition-wise to, make sure that you're being followed regularly by an optometrist or an ophthalmologist. If you've got a diagnosis already of cataracts or glaucoma or macular degeneration, then you're being seen already by an ophthalmologist, which is a medical doctor who specializes in eyes, as opposed to an optometrist who is primarily responsible for refraction and screening for eye diseases. So when you do have an eye disease, in addition to dementia, you want to make sure that you're being treated for that eye disease as well. Dementia, again, it's partly what's going on with your vision and your eyes, but it's also what's going on with your brain's ability to process the visual information that comes in. And it just gets a smaller and smaller capacity. So the strategy that we use in that case is maximizing usable vision. So we look at lighting and can make recommendations to, optimize the lighting, eliminate glare, place objects that the person needs to see right in front of them, use night lights to illuminate the way between, so for example, the bedroom and the bathroom. Even healthy eyes at 80 years old are going to take about 8 times the amount of light that a 20-year-old's eyes need. So lighting can make a really big difference. The use of contrast, so, serving coffee in a white cup as opposed to a dark cup helps know how much coffee you have. The use for significant vision loss, just placing items in the very same place time after time, it can really help a person find what they need. So just those kinds of strategies. Again, it's all functional. It all is a lot of common sense. But if you don't have the framework to kind of look at an environment, you know, home is home. But when physical changes happen and cognitive changes happen, making simple changes to your home can make it a lot more usable for you.
We often have people express concerns about the fact that their spouse will wear the same clothes for 7 days in a row, or that they'll put on 3 or 4 different pairs of underwear.
Layers.
Layers.
Yeah.
Do you have recommendations when clothing choice is a difficulty?
Yeah, that can be really hard. So there are clothing items available that are just easier to take on and off. You know, sometimes it's just too hard to do buttons. And so once you get them done, you don't want to undo them because you're going to have to do them again. So you can use, you know, pullover sweatshirts, sweatpants instead of jeans, for example. So simplify the clothing. You can approach it in a really matter-of-fact way. You know, if a person isn't able to determine that they need to change clothes, and say, look, it's Tuesday morning. This is your day to put on fresh clothes. Here are your clothes. Would you like me to help? And, you know, kind of start there. You don't have to be bossy, and you don't have to be, you know, mean about it, or you can say it in a way that they can hear. Manipulation can really help you, can be your best friend. It's Tuesday. Everybody changes their clothes on Tuesday. Everybody on the block changes their clothes on Tuesday. So here are your fresh clothes. Put the new clothes that you want them to see right in front of them so that they don't even know there's an option for more stuff. Simplify it. But yeah, that's one of the really hard things. Insight is one of the things that is impacted early on with dementia. And so it can be part of that, not really knowing what you're dealing with, if it's dementia or if it's just a personality. But we know rational people change their clothes. So adding some structure to the day, you know, it's 10 o'clock on Tuesday morning. This is when we change our clothes. And that's what you need to do now. So would you like me to help? Or would you like me to leave?
How about toothbrushing and shaving? Those kind of hygiene issues.
Yeah, that can be hard too. And, you know, even when teeth start to hurt, people don't always think to brush their teeth. So I guess, again, you know, adding the structure in and establishing those routines from the get-go. And again, you don't have to be bossy about it. You can be very matter of fact. Here's your new toothbrush. It's the kind that does the brushing for you. You just put it in your mouth. You stand right beside them. You brush your teeth at the same time. You show them exactly how it goes. This is, you know, you swish and then you spit it out. And you talk them through it one step at a time. It's maybe more complicated than we think about. These things that we routinely do that come down to one step at a time. And it may be that you have to, we call it hand over hand. You stand behind the person, you cover their hand with your hand, and you brush the teeth with them. Maybe they just can't figure out what to do anymore. Again, it depends on what the problem is that they're experiencing.
How do you handle combative behavior to protect yourself and the individual?
Yeah, you take a step back, you pick and choose your battles. And again, you really think about what's at the heart of the combative behavior. And I can't say it, I mean, I know this is an example that we use in healthcare a lot, but urinary tract infections and heart disease and congestive heart failure exacerbation are two of the most common reasons that people go to the emergency room. So always be on the lookout for foul smelling urine, urgency, and dehydration. Happens very, very regularly, especially in cooler weather because you don't have the sensation that you need to drink as much.
Do you have any specific recommendations for devices, tracking devices when you have runners?
I don't, and that was something I meant to look up before tonight. But what I can say is there are many choices. I would look on the Alzheimer's Association page to see if they have any specific ideas. And in fact, Lynn, before I send you this outline, I'll look that up and see what they recommend and put that in the outline.
Okay, thank you.
Mm-hmm.
As a loved one becomes increasingly angry and more physical in that expression, how do you assess for caregiver safety?
Yeah, that's something that can change, really frequently. Fortunately, remember that adrenaline only lasts so long. So those outbursts are not going to last forever because they're adrenaline fueled. And again, think about what's causing it. What's the real problem?
And then one last question.
Mm-hmm.
Do you have recommendations on what to do if the loved one threatens to call 911 or the police on a caregiver who's trying to keep them safe?
Right, it happens all the time. I think, probably be proactive and call the police department ahead of time and say, you may be getting 911 calls go to local police stations and just say, look, here's my name, here's my situation, here's my family member's name. You may be getting calls from them. You're very welcome to come out and respond to their concerns, but they have dementia and they're not always rational. And this is what I'm doing, but I would let them call. Mistrust is a natural reaction of not knowing what to expect, right? If you wake up and you don't know where you are and you don't know what's going to happen that day, you fill in the blanks. And so it's very common for people to not trust the people that they've always known. It's not personal. It's just what their brain is going through.
Kathy, thank you so much. This has been so helpful. And those of you that are on the call, will send you Kathy's outline, and she's also got some websites that will be helpful to you, and we will send those out to you as well. So thank you so much.
Oh, it's been my pleasure. Thank you again for inviting me. I really, really love spending time with your group. So thank you. And
we have some thank yous on the Q&A in the chat as well.
I appreciate that.
Thanks, Kathy.
Mm-hmm. Take care.
Thank you all for attending, and we'll see you next month when we'll be talking about the Area Agency on Aging and Disabilities, and they'll be talking about what resources are available in the community. Thank you all.
Take care, everybody.
Bye-bye.